Welcome to our deep dive today. You shared a really thought-provoking article with us
Oh, yeah.
about how shortages of resources can actually make inequality worse in organizations.
Hmm.
The article focuses on healthcare,
Right.
but get ready for some insights that apply to, I think, really any field that has to deal with limited resources.
Absolutely, yeah.
So it's not just going to be for healthcare folks, although
It'll
be
do.
very interesting for them.
For sure.
Um,
So this article
yeah, go ahead.
is called Flexible Austerity, Negotiating the Unequal Effects of Resource Shortages in Racialized Organizations. And it's by Alexandra Brewer.
Okay.
And it was published this year in the American Sociological Review.
Okay, so we're going beyond just kind of the simple, like, shortages are bad, right?
Yeah.
We all kind of already know that we're
Well,
going to uncover how decisions made during a shortage, particularly by those in charge, can have a huge impact on who gets what.
yeah, exactly.
And the study focuses on a shortage of IV opioids at a particular hospital, an urban academic hospital.
Right, which they call Metro University Hospital, or MUH.
Okay.
But the lessons here, I think, are much broader than just this one hospital.
Yeah, for sure.
And the ways that these kinds of things can play out.
Okay, so before we even get into the shortage itself, the article points out that organizations are often like ground zero for these inequalities that we see.
Right.
So what makes organizations these kinds of hotbeds for inequality?
Well, I mean, think about it. Like, where do we get most of our resources in life? You know,
Yeah.
jobs, education, healthcare.
Right.
All of it comes from organizations, right?
Yeah.
But these organizations aren't neutral. They come with all these built-in power dynamics and biases.
Right.
So when a shortage hits, the scramble for resources gets filtered through those pre-existing systems.
So it's not just this random free-for-all.
Right, exactly.
Like you're saying, those systems determine who actually gets prioritized.
Yeah.
Even when it comes to something that you would think would be pretty basic, like pain medication.
Absolutely.
It's not that simple.
right.
And that's what the study digs into, right? It's not just like who gets more.
Right.
It's about these often invisible ways that the people in charge,
Yeah.
in this case, like doctors and nurses,
Mhm.
make decisions that can actually like really put certain groups at a disadvantage, often without even realizing it.
Yes, exactly.
And so this study looked at this hospital, MUH, both before and during the opioid shortage
Yeah.
to see how things changed.
Right. So having that before and after comparison is really key here.
Okay.
You need to see how things work before the pressure hit
Okay.
to really understand how the decision-making changed under stress.
So the article calls pain management, it calls it a particularly potent example.
Yeah.
Why is pain management a particularly potent example of this?
Well, if you think about it, pain, unlike, say, a broken bone, it's totally subjective. You have to rely on the patient to tell you how much it hurts.
Yeah.
And there's no objective test to confirm it.
Yeah.
So that leaves a lot of room for bias to kind of creep in.
I mean, we know historically there are tons of biases around race and pain, unfortunately.
Unfortunately, yes, there's this long, terrible history of Black people being seen as less sensitive to pain,
Right.
going all the way back to slavery, really.
Mm-hmm.
And, that perception still, unfortunately, affects how pain is treated today.
Yeah.
Yeah.
The article also mentions that hospitals are under constant pressure
Oh, for sure.
to manage their costs
Mm-hmm.
and to discharge patients quickly.
Yes.
How does that play into everything?
Well, I mean, if you think about it,
Yeah.
if someone needs a lot of pain management, they might stay in the hospital longer,
Right.
which means using up more resources.
Right.
And in a system that's like more and more focused on efficiency and the bottom line,
Mm-hmm.
there's a real incentive to, kind of minimize those costly patients, however you define that.
Okay, so we've got this setting, right? We've got a hospital under pressure.
Right.
We've got this subjective condition like pain. And then we've got these, pre-existing biases
Yes.
about race and pain. And then on top of that,
Right.
the opioid shortage hits.
Right.
What did the researchers find when they looked at what happened when the shortage hit?
Okay, so this is where the idea of flexible austerity comes in.
Okay.
But before we jump into that,
Yeah.
let's actually look at how things worked at MUH before the shortage started.
Okay.
The author calls it constrained enabling, which sounds a little contradictory.
It does. What does that even mean?
Yeah, constrained and enabling at the same time.
Right. It basically means that the clinicians, so the doctors and nurses, they were technically following the guidelines for managing pain, which meant at the time, prescribing 5-U opioids pretty freely
Okay.
based on what patients said about their pain levels.
So they were like enabling the
Yeah.
use of these strong medications.
In a way, yes.
But they felt constrained
Mm.
because even while they were following these guidelines, they also had all these internal judgments about which patients they felt truly deserved that pain relief.
So on paper, they were following the rules, but
Right.
in their heads,
Yeah,
they were judging some patients as not really needing it.
exactly.
Yeah.
Wow, that's so interesting.
Think of it this way. Like, imagine you're on a really strict diet, where you're supposed to eat a certain number of calories a day.
Yeah,
So, like, you might be following those rules perfectly, but still secretly craving those, like, forbidden snacks. You know
Right.
what I mean?
you do. Yeah, totally.
So in this case, the doctors, they felt obligated by, like, evidence-based medicine to prescribe these opioids.
Yeah.
But they were struggling with their own, like, internal biases
Right.
about whether some patients were truly in that much pain or maybe just seeking drugs.
So they're prescribing the medication,
Yeah.
but feeling this internal tension
Yeah, exactly.
because their own personal judgments. Right.
Don't line up with, like, what the medical guidelines say to do.
Exactly, yeah.
Interesting.
Yeah, and you can really see this tension in some of the comments they made.
Okay.
About how some patients were, quote unquote, abusing resources or like, taking up beds that could be used for more deserving cases. Like, there's a lot loaded in that language.
Yeah, for sure. And that's
Yeah.
all before the shortage even hits, right?
Exactly.
So what happens when the hospital actually starts running low on these IV opioids?
Right.
I'd imagine that would just make this situation even worse.
You would think so, right?
Yeah.
But here's the surprising part. Clinicians actually saw the shortage and the new rules it led to as a good thing.
Really?
Yeah.
Why would they see a shortage as a positive?
It's so interesting, right?
Yeah.
Well, because it gave them a reason to deny opioids to the patients that they already viewed as undeserving.
Okay.
Remember, before the shortage, they felt constrained by those evidence-based guidelines
Right.
to prescribe based on, reported pain.
Mm-hmm.
But now suddenly they could say, sorry, we can't give you more because of the shortage,
Right.
even if that wasn't always entirely true.
So the shortage becomes a convenient excuse
Yeah.
to justify decisions that were already maybe being driven by some bias.
Exactly. It takes the pressure off them to treat those suspected drug seekers.
Yeah.
And it helps them, justify discharging patients faster,
Right.
which, lines with those cost-cutting goals.
It's almost like the shortage gives them permission
Yeah,
to act on these judgments that they already had, but they couldn't always express.
exactly.
Yeah.
And that's what Brewer calls flexible austerity.
Okay.
It's about holding back resources, but doing so in a way that's uneven and based on these pre-existing biases.
So it's not just that there's less to go around, it's about who gets to decide.
Exactly.
How that, like, less gets divided up.
Right. And in this case, it meant that the shortage disproportionately affected Black patients, even though the policy itself wasn't, like, specifically written in a way that targeted them.
Right, yeah.
It wasn't like it said, Black patients can't get this.
Yeah.
It was this neutral-sounding policy.
Right.
But the way it was used was not neutral.
Interesting. So we've got this, like, flexible austerity happening.
Yeah.
Where a shortage becomes an excuse to withhold resources from certain groups.
Right.
And again, it's not just about a lack of supplies.
Exactly.
It's about how those limited supplies are being used.
Yes.
And ultimately, who gets left out.
Yeah, and what's really fascinating is how the clinicians in the study, like how they rationalize their actions.
Right.
They were well aware of, like the guidelines for ethical pain management.
Right.
But they somehow managed to justify acting against those principles.
That's what I was thinking. It seems like such a contradiction. They're
Yeah.
supposed to be following, like, evidence-based medicine, but then they're making these decisions that clearly go against that very idea.
Yeah. Right. And that's actually one of the most, like, revealing aspects of this study.
Okay.
It shows how easily, like, implicit bias and organizational pressures can influence decision-making,
Yeah.
even in professions that, really pride themselves on objectivity.
All right.
You think of doctors as being, like, super objective.
Yeah, they're supposed to be.
and following the science.
Right.
But this study shows that it's not always that simple.
So the author talks about clinicians legitimating austerity practices. And it sounds like what she's saying is they're kind of creating these stories in their minds
Right.
that make their actions seem okay.
Yes,
It's
exactly.
even necessary, like, we have to do this.
Right. They're building these narratives that allow them to feel comfortable with what they're doing.
Both to themselves and
Yeah.
to others, like, if they have to explain it.
Exactly.
So how do they do that? How do they convince themselves that they're doing the right thing when they're clearly withholding pain medication from patients who need it?
Yeah, well, one way they did this was by kind of shifting the blame.
Okay.
So instead of acknowledging their own biases, they pointed to the shortage itself as the reason they couldn't provide adequate care.
So it's like they're saying, it's not me, it's the shortage, my hands are tied.
Yeah, exactly.
It becomes this convenient scapegoat.
Exactly.
Yeah.
And it lets them avoid facing, the uncomfortable truth, which is that their decisions are based on something other than a patient's actual medical needs.
It's like they're absolving themselves of any responsibility for the choices they're making.
Yeah, the shortage becomes this, external force that dictates their actions rather than their own internal judgments.
There's this quote in the article that I thought was really striking from a doctor who says, "It's not me, it's the hospital, it's Puerto Rico, it's the environment."
Wow. Yeah.
I mean, come on.
That's a striking quote, isn't it?
Yeah.
It really captures this idea of, deflecting blame and pointing fingers elsewhere.
Yeah.
So by blaming the shortage, the hospital, even like a natural disaster in Puerto Rico, she's creating this distance between herself and the decision to withhold medication from a patient in pain.
Yeah. It's really something.
Yeah.
But it's not just, individual doctors doing this.
Right.
The author argues that, the hospital itself helped to create this culture where it was okay to justify this unequal treatment.
Absolutely.
Especially in how they talked about that new 24-hour rule, where they limited the amount of IV opioids that any patient could get.
Right, yeah.
So instead of presenting it as this is a necessary but unfortunate compromise due to the shortage, they framed it as this fair and universal rule that applies to everyone equally.
We're all in this together kind of thing.
Yeah, exactly.
But as we've seen, that's not how it actually played out in reality. The policy might have been written in a colorblind way, but the way it was actually used was anything but fair.
Yeah, it reminds me of that saying, some animals are more equal than others. On paper, everyone's the same.
Right.
But in practice, some people get preferential treatment.
Yeah, that's a great analogy.
And that's what makes this kind of discrimination so insidious. It allows organizations to deny that they're doing anything wrong.
Right.
They can just point to the policy and say, look, we treat everyone the same.
It's not us, it's the policy.
Yeah, exactly.
Even as they're selectively applying it to disadvantage certain groups.
The author actually uses a term to describe this.
Okay.
She calls it colorblind organizational processes.
Yeah, it's almost like a way for institutions to perpetuate discrimination.
Yeah.
While hiding behind this mask of equality.
Yeah, exactly.
And it's so dangerous because it makes it really hard to challenge. When you point out the unequal outcomes, they can just say, well, that wasn't our intention.
We didn't mean to do that.
Right. We were just following the rules.
It's like they're creating this illusion of fairness.
Yeah.
When the reality is that real harm is being done.
Precisely. And it highlights the need to look beyond just the written rules.
Okay.
And pay attention to how they're actually being used and interpreted.
Right.
Because that's where you see the real impact.
So we've got these individual clinicians, shifting blame, and then we've got hospitals promoting this image of neutrality, and it's all under this umbrella of flexible austerity,
Right.
Which paints a pretty grim picture of how resource shortages can make these inequalities, these pre-existing inequalities, even worse.
Exactly.
But it's not just an abstract concept, right?
Yeah, not at all.
This has real-world consequences for the Black patients at MUH.
Absolutely.
And we've talked about some of them already, less pain relief, being discharged too early, even being given riskier prescriptions.
Right.
But there are other, even more disturbing examples of how this unequal care played out.
Yeah.
One that really stood out to me was the issue of patients leaving the hospital against medical advice.
Yes, that's a big one.
Or what they call AMA.
Right. This is where we see patients essentially taking matters into their own hands.
Okay.
They're so unhappy with their care,
right?
So desperate for relief
that
they choose to leave the hospital even though their doctor hasn't officially discharged them.
And the study found that this was happening a lot more to Black patients.
Yes.
During the shortage.
Yes, and it's directly linked to this flexible austerity we've been talking about.
Okay.
They're being denied the pain medication they need,
Yeah.
labeled as drug seekers,
Right.
and basically just pushed out the door before they're ready.
That's awful.
Yeah.
And to make matters worse, the clinicians often saw this as proof that they were right all along.
Right. Isn't that crazy?
Yeah.
They interpreted the patients leaving AMA as evidence that they were just trying to manipulate the system.
Yeah, it's like a self-fulfilling prophecy.
It is. It's a classic example.
Right.
They deny care based on this biased assumption, and then when the patient reacts negatively to that, they use that reaction to justify their initial prejudice.
It's a vicious cycle.
Totally. It's a no-win situation for the patient.
Yeah. If they complain about their pain, they're labeled as, like, difficult or demanding.
Right.
But if they try to leave, then they're seen as, manipulative or non-compliant. There's no way for them to get the care they need.
Exactly. And the saddest part is we don't actually know what happened to these patients after they left AMA.
Oh, right.
The researchers weren't able to track their outcomes.
That's kind of a scary thought.
It is.
Like, did they go to a different hospital?
Yeah.
Did they end up suffering at home?
Yeah.
Did they turn to, like, other, potentially dangerous ways to manage their pain?
Right, exactly, because they weren't getting the help they needed from the medical system.
It's really sad.
Yeah, and it highlights one of the limitations of this kind of research, right?
Okay.
We can't always know the full story.
Yeah.
But it raises these really important points about the need for better systems of care.
Right.
Especially for those who are, already most vulnerable to bias and discrimination.
It's not enough to just, like, hope that the individual clinicians will always do the right thing.
Exactly. We need policies and practices that actively work against these, like, ingrained inequalities.
Yeah, we can't just rely on good intentions.
Right, exactly. We need systemic change.
So flexible austerity isn't just this abstract idea.
No.
It has a real impact on people's lives, their health, their well-being.
Yes.
And in some cases, it can have some really devastating consequences.
That's right. And it's a stark reminder that even something as seemingly neutral as a shortage can be used to, like, reinforce existing power dynamics and marginalize those who are already disadvantaged. It's a real wake-up call for all of us.
Okay, so we've kind of established that flexible austerity is more than just, like, a fancy term, right?
Right.
It's a real phenomenon, and it has, serious consequences, especially for, folks who are already marginalized. Which kind of makes me wonder, like, how do places like MUH get away with this?
That's a key question.
Yeah.
And this is where the study gets really interesting, I think. It's not just about, individual biases like we've been talking about.
Right.
The problem is, like, woven into the very fabric of the hospital, its organizational structure, and how it responds to pressure.
Yeah. So it's not just a few bad apples, so to speak. It's like the whole system
exactly.
is set up in a way that disadvantages certain groups, even when, the policies themselves seem neutral.
Exactly.
Yeah, that's really interesting.
Yeah, the study highlights how, like, an organization's mission and financial pressures can really create, like, a breeding ground for this flexible austerity.
Okay.
So in MUF's case, being a private academic hospital with this big focus on efficiency and cost cutting,
right,
really created, like, fertile ground for these inequalities to take root.
And, it's like they were so proud of their reputation as, like, a top research institution, right? Okay. But that commitment to evidence-based medicine just seemed to vanish when it came to, Black patients in pain.
It's so interesting how that works, right?
Yeah.
That's, like, the insidious nature of flexible austerity.
Okay.
It allows these organizations to, like, preach certain values and principles while simultaneously acting in ways that completely undermine those things.
Right. It's like saying one thing and doing another.
Exactly.
Yeah.
And it makes you think twice about taking institutions at their word.
For sure.
You have to look beyond the PR and see if their actions, their policies, their results actually match up with their stated values.
Yeah. It's making me think about, like, if I've seen this happening in my own life and just didn't, like, have the language to describe it before.
Totally. Yeah.
So the author points out that MUH's reliance on private insurance also played a role in these biased decisions.
Absolutely.
And it's almost like there was this unspoken belief that, like, Black patients who are more likely to be uninsured or on Medicaid were kind of, like, a drain
Yeah.
on the hospital's finances.
Yeah, that's such a critical point.
Yeah.
The way we fund healthcare in this country is inherently unequal.
Mm-hmm.
And that inequality inevitably shapes how care is delivered.
Right.
Like, who pays for the services becomes a factor in who gets those services.
Yeah, it's a crazy system where, hospitals are essentially rewarded for treating, patients who can pay, and then the patients who can't are seen as kind of a burden.
Exactly. And that's where this whole idea of deservingness comes back into play.
Yeah.
Like, who gets labeled as, like, worthy of receiving care.
Right.
And who's seen as less deserving.
Yeah.
And those judgments, they're often based on things like race and class and insurance status.
Right.
Rather than a person's actual medical needs.
It's like there's this, hidden system of triage happening.
Yeah, totally.
But instead of being based on, urgency, it's based on who has the most resources and the right, social markers. Mm-hmm. And those are the people that get prioritized. And then the people who don't get kind of left behind.
That's a really powerful way to put it.
Yeah.
And it underscores why it's so important to, keep fighting for a fairer, more equitable approach to healthcare.
Right.
We can't let financial factors determine who gets quality care.
Yeah.
Everyone deserves to have their pain taken seriously and treated with compassion.
So, this deep dive has been, really eye-opening, to say the least. It's made me rethink, so many things. Mm. But I'm sure our listeners are wondering, what can we do about all this?
That's the big question, isn't it?
Yeah.
But, the good news is awareness is the first step.
Yeah.
Research like this can be a really powerful tool for change.
Okay.
By shedding light on how flexible austerity works, we can start to, dismantle these harmful systems.
So, knowledge is power, as they say, but it has to be more than just knowing, right?
Exactly. Awareness needs to be followed by action.
Okay. So what kinds of actions can people take?
Well, it starts with, being attuned to these dynamics in our own lives.
Okay.
So, pay attention to how resources are allocated in your workplace, your community, your social circles.
Right.
Look for those subtle signs of bias, those instances where people are treated differently based on their race, their class, or other social markers.
So, you're saying we need to look for those moments where, seemingly neutral rules or decisions are actually benefiting certain groups at the expense of others.
Exactly. And when you see it happening, don't be afraid to speak up.
Okay.
Challenge those assumptions, ask questions, advocate for a more equitable approach.
Yeah, it sounds like you're calling for a collective raising of consciousness. We need to be aware of these dynamics and then actively work to disrupt them.
That's a great way to put it.
Yeah.
We can also support organizations and policies that, promote fairness and prioritize the needs of those who are most vulnerable.
Right. So whether it's, voting for leaders who support, a more just healthcare system or donating to organizations that are, fighting for social justice.
Yeah, exactly.
We can make choices that align with our values and hopefully contribute to, creating a fairer world.
Absolutely. We can't just sit back and accept that flexible austerity is inevitable.
Right.
The choices we make, both individually and collectively, can make a difference.
Well, this has been a truly powerful conversation, I think.
Yeah, me too.
He's given us all a lot to think about.
For sure.
And more importantly, I think, a lot to do.
Absolutely.
So I hope our listeners are feeling, empowered to challenge inequality wherever they see it.
I hope so, too. We all have a role to play in creating a world where everyone's needs are met, regardless of their background or circumstances.
Yeah, so thank you so much for joining us on this deep dive.
Of course, it was my pleasure.
Into flexible austerity, and we hope it sparked some, critical thinking.
Yeah.
And inspired you to join the fight for a more just and equitable world.
For sure.
Until next time, stay curious.
Yes.
And keep questioning the systems around you.